Role of MRI in epilepsy. Outline introduction إن شاء الله نناقشها causes and protocol. Epileptic seizure is a transient occurrence of the sign and or symptom due to abnormal, excessive, or synchronous neural activity in the brain. Epilepsy is a disorder of the brain characterized by enduring a predisposition to generate epileptic seizure and by a neurobiological, cognitive, psychological, and social consequence of this condition. There are three levels of the clinical feature of epilepsy defined: seizure type, epilepsy type, and epilepsy syndrome. And different categories of etiology, structural, genetic, infectious, metabolic, and immune or unknown should be considered. الابيليبسي and seizure طبعا هي different type of epilepsy. اللي تبدي هي البارشال سيجر اللي هي تكون البيشنت بيها conscious او اللي another name اللي هي الفوكال onset of seizure اللي originated into small area of the brain in one side of it. راح ينقسم لنا اذا اما اللي هو السمبل partial اللي هي remain patient conscious واللي تحول لنا بعدين اذا complex partial اللي يصير عنده الاورا اللي هو loss of conscious. بعدين الكومبلكس partial seizure sometimes we develop into the generalized seizure اللي يعني يصير two side of a brain originated abnormal cell of a brain in both side of a brain اللي راح يصير tonic seizure with unconscious. Epilepsy in general population, if first seizure ever هي 4% of the population. Epilepsy 1% of the population. Epilepsy of uncontrollable هو 0.04 of population اللي هو تقريبا 80% of epileptogenic focus can be detected in MRI. The MRI always should be performed in non-urgent setting, excluding those patients with genetic generalized epilepsy or benign rolandic epilepsy of the childhood with the centrotemporal spike. In urgent setting, especially in patients اللي عندهم fever, trauma, or neurological deficits such as stroke, طبعا دائما تبقى CT remain concordance of lesion seen in MRI with either clinical and يعني نشوف الداتا بالإضافة إلى الليجن اللي نشوفها بالMRI ويا EEG indicate possible originated of seizure lateralization of one to one cerebral hemisphere is crucial for appropriate patient assessment. The MRI is also help in defining the surgical treatment option in patients with the intractable epilepsy and in post-surgical setting. الإيمج بروتوكول طبعا هو اكو بروتوكولات بالإبيليبسي but most of them depend on the same انه لازم نحصل high resolution or small focal of view and a thin slice to detect even the very small lesion. Right. The appropriate MRI in the brain patient with epilepsy should be include راح يشمل لنا high resolution volume راح يشمل لنا T1 اللي يكون slice thickness 1 ملم with the inversion recovery IR. IR ما قد نستفاد منه just in young children اللي يكون poor differentiation بالwhite and gray matter. راح نستخدم IR عمود for good viewing of white matter and gray matter in this age. And the second view نستخدم الsequence هو T2 with the stir and the flare image. And this equal or not exceeding 3 mm thick of slide with at least 2 slides oriented toward the hippocampus angulation or covering the possible EEG epileptogenic area. يعني it's very important to orientation of the sequence toward the area of the temporal, especially hippocampus, because 60% of epilepsy originated in the temporal lobe. And sensitive sequence اللي هو السوي not benefit in all patients, just in patient had to identify calcification and blood product such as the storage Weaver syndrome. The coronal images are very helpful in depicting anatomical detail of temporal lobe structure, and especially of the hippocampus as well as the cortex, where the most epileptogenic lesions are encounter. نرجع انه الجادولينيوم والكونتراست انهانسمنت تبقى عليها انه debatable, not helpful in all patients, just in patients عندهم vascular lesion. During first 2 years of the life, the identification of the cortical alternation difficult, so it's better to return MRI in after 1 to 2 years. This is البروتوكول epilepsy انه T1 نستخدم لو باللم thickness وال T2 stir and clear equal or less than 3 mm in axial and coronal direction toward the hippocampus. will also can the some patient نستخدم الهيموجلوبين classification السوي in special cases. Another protocol T1 and clear T2 سوي and contrast enhancement benefit in brain tumor and storage Weaver syndrome. Epilepsy, there are many causes of epilepsy, many type of epilepsy causes of epilepsy, structural alternation, malformation. هي اولا كمان هو malformation of cortical developmental, focal cortical dysplasia, tuberous sclerosis, Schizencephaly, subcortical band heterobia, and gray matter heterobia. Polymicrogyric, hemiparesis, Schizencephaly, hypothalamic hamartoma. Another vascular malformation, cerebral angioma, storage Weaver syndrome, AV malformation, hippocampal sclerosis, hypoxic ischemic hemorrhage disorder such as stroke, hypoxic ischemic injury, cerebral hemorrhage, or a traumatic brain injury, tumor like dent and ganglioglioma and porencephalic cyst. Another causes such as metabolic etiology or immune etiology or infection etiology. The most common causes that cause intractable epilepsy that not responsive to treatment will mesotemporal sclerosis with developmental, especially in the children, like focal cortical dysplasia, heterobia, polymicrogyria, hemimegaencephaly, Schizencephaly, or epileptogenic tumor, ganglioglioma, demetiblioxanthos, astrocytoma, and hypothalamic hamartoma, or gliosis, or miscellaneous like rosencephalitis and cavernous hemangioma, or neurocutaneous syndrome like storage Weaver and tuberous sclerosis. This is picture to identify the causes of intractable epilepsy in the brain, like mesotemporal sclerosis. We see this area, small area of the hippocampus, or this region in the temporal lobe. We identify the tumor, and this area we see elevated large of megaencephaly. This is also the site for the cavernous hemangioma or the heterobic gray matter. Also, malformation of the cortical development, migration, and gyration disorder. The development disorder have been increasingly recognized on MRI in the children and young adults with epilepsy, counter for up to 50 of pediatric cases of intractable epilepsy and about 25% in those young adults. بس عفوا أستاذ صوتي مسموع؟
بلي مسموع. اوكي واضح بدي.
نعم. This abnormality of the cortical development included the following entities, which is maybe also coexist in some patients and involve different brain regions simultaneously: the focal cortical dysplasia, gyri, pachygyri, heterobia, Schizencephaly, hamartoma, or cavernous malformation. Typical MRI findings are the presence of abnormal cortex, which may be thickened or may be too few or too many abnormal gyri. They may also abnormal sulcus cortical signal abnormality and alternation of underlying white matter with the blurring and loss of normal cortical subcortical differentiation on MRI. The most common of these type was focal cortical dysplasia, malformation of the cortical developmental اللي about 5 to 25% of the focal epilepsy. Most common cause of refractory extratemporal epilepsy, especially in the children. MRI finding, we can see the septal cortical and subcortical high sign hyperintense T2 نشوفها often located at the bottom of the deep sulcus player gray to white matter interfere and the focal cortical thickening, and we also see the transmantle sign. We see as this is thickening of the cortex, and also we see the hyperintense sign. This is another cause of the cortical dysplasia. Cortical dysplasia we see associated with the mesotemporal associated with the mesotemporal sclerosis. We call the dual pathology. Usually focal cortical dysplasia associated with the mesotemporal sclerosis. We see in this patient two lesions اللي هي cortical dysplasia and mesotemporal sclerosis. This is another case. We see the focal cortical dysplasia, the hyperintense in the T2. The transmantle sign we also see in the focal cortical dysplasia. Sometimes the hyperintensity is seen extending from subcortical area to the margin of the ventricle. This is called the transmantle sign, and this is finding represented arresting the neural migration. We see this in this patient transmantle sign. We extended from the ventricle to the cortex. This is another transmantle sign. Heterotropy is another cause are characterized by the presence of normal neuron in abnormal location, and they are usually divided into the three types depend on clinical and imaging feature. He was subependymal, periventricular, and subcortical, and the third one, the land band or laminar heterotropy. Heterotropy typically show the same sign as a cortical gray matter in all sequence, and they may be associated with other abnormality of the cortical development, such as Schizencephaly. This is the type of heterotropy we see on the lateral. We see on the lateral wall of the lateral ventricle. This is another type of heterotropy, band heterotropy. We see this gray matter band, the sign hypotense sign. Schizencephaly is a cleft in brain that connects lateral ventricle to the subarachnoid space. The cleft is lined by polymicrogyric gray matter. The open lip Schizencephaly characterized by separation of the cleft wall, while the closed lip Schizencephaly characterized by cleft wall in apposition to each other. Patients have the seizure hemiparesis, which is proportionate to the size of the cleft and more common in open lip type. We see this Schizencephaly opening of lateral ventricle to the subarachnoid area. We also into T1 they see the same. Hibernoma, the popcorn ball, which is hemosiderin remnant in the T2 and the CW most sensitive due to the susceptibility effective bloom. The punctate hypotense fossa we call the a black dot on T2. And also look for associated with the developmental venous anomaly if the single hibernoma. CT negative in 50% and calcification in 50% of the cases. We see this a black dot of the cavernous. It's also we see in CT scan calcification. We see in CT scan also this is the associated with the developmental venous anomaly, and in MRI we see developmental venous anomaly as the sign void sign in MRI. The polymicrogyric with many of the gyri in the brain. We see this a lot of gyri. Another causes of epilepsy were related to the structural brain alternation genetic syndrome. Several genetic and congenital syndrome are associated with epilepsy, including some of better known neurocutaneous syndrome. اللي هي تشمل لنا neurocutaneous syndrome هو التوبرال سكليروسيس والستورج ويبر syndrome. tuberous sclerosis هو multi-systemic congenital syndrome with the widespread CNS anomaly. Neurological manifestation include epilepsy, cognitive impairment, and approximately 90% of the patient have seizure with intractable epilepsy developing in 25 to the 30% of the patient. الكي فايندنج ان البراين هيشوف الكورتيكال and subcortical tubers, subependymal nodule, subependymal giant cell astrocytoma, and white matter abnormality. We see tubers, hypertense, these tubers, cortical tubers, and also we see the subependymal nodule on the lateral border of the lateral ventricle. This is another case. We see nodule, multiple cortical nodules. In the case of the tuberous sclerosis, into the CT scan, we see the calcification of these nodules. Another neurocutaneous syndrome is storage Weber neurocutaneous syndrome, typically present with the facial angiomas in the trigeminal nerve distribution and ipsilateral meningeal angiomatosis. Clinically, patients have intractable seizure, hemiparesis, hemianopsia, and mentally retardation. اللي هو عادة يصير malformation بالinternal cerebral vein and dilation. MRI findings include dual angiomas in parieto-occipital region, cortical calcification subadjacent to the cortex, and white matter, typically in parieto-occipital region. Atrophy of ipsilateral cerebral hemisphere, angioma site. Enlarged and elongated globe of the eye, prominent enlargement, the subependymal and medullary vein, and secondary sign of the cerebellar atrophy involve paranasal sinuses and mastoid cell and the clavarium. Also occur enlarged the choroid plexus. We see this, the hypotense with the brain atrophy at the side of the angioma. This is also can be seen. Hypotense pale angiomas were seen in right cerebral hemisphere with the atrophy of this side. This is another, we see storage Weber into the T2 SOE and the contrast enhancement. This is another case where 4 years old boy with the storage Weber. We note the atrophy of the left posterior cerebral hemisphere and with the leptomeningeal enhancement and thickening, as we see. This is meningeal thickening. Another cause of epilepsy, which is very important, is hippocampal sclerosis, with another name mesotemporal sclerosis. Is the most common abnormality found in the temporal lobe resection of the patient with intractable epilepsy undergoing surgery. At pathology, this entity identified by the presence of a neural loss and gliosis. Typically, MRI findings are hippocampal volume loss and increase the T2 signal within the abnormal small hippocampus. Further imaging of MRI in patients with the mesotemporal sclerosis, loss of internal architecture of the hippocampus, atrophy of ipsilateral mammillary body and fornix with the dilatation of adjacent temporal horn. MRI identify up to 90% of the cases of the hippocampal sclerosis, and hippocampal sclerosis may be also bilaterally in up to 20% of the cases. Some patients, as we say before, have the additional epileptogenic area, either temporal or hippocampal or even extratemporal, which is referred to the dual pathology. The most common associated occur between the cortical dysplasia and hippocampal sclerosis. The surgery is curative in up to 7 patients with hippocampal sclerosis, especially in those with not having dual pathology. The mesotemporal sclerosis, the hippocampal volume loss mean the neural losses, and the hippocampal high sign mean the gliosis. We see the hyperintense intuitive and flare. We see the the temporal sclerosis, we show the small cells, and if we compare it with another side and contain the hypertense entity. This is another, we see the shrinkage and hypertension. This is the dual pathology associated with the focal cortical dysplasia. This is another case. We see the shrink and hyperintense in hippocampal area. This is the same patient after successfully treated with the amygdalo-hypocampectomy on the left, as we see, after surgery. Epilepsy-associated tumor, all brain tumor may present with epilepsy, but there are some typically epilepsy-associated tumor. These tumors are share the following characteristic, and they arise in the cortical region, often located in temporal lobe, closely related to the developmental malformation, and typically seen in adult and young adult. Characterized by the benign behavior and slow growing and the sharp delineation, and usually show absence of edema. Show the sign of the chronicity, such as the bone remodeling and the scalloping of adjacent skull. In most common epilepsy-associated tumor, ganglioglioma, dentate, pleomorphic, astrocytoma, and hypothalamic hamartoma. This is case of the ganglioglioma, as we say. We cause, because of chronicity, we cause the scalloping of brain. Then also we see this tumor, and also called the scalloping. This is another case in the 11 years old presented with intractable partial seizure. We see the lumpy appearance of the tumor with the scalloping of the skull. Lumpy appearance with the scalloping. Another cause, post-traumatic epilepsy, not uncommon condition. Head injury can cause the damage to the cortex, most frequently in frontal lobe or in the temporal region due to underlying adjacent bony structure. The cerebral contusion at this site may leave the hemosiderin deposit and gliosis, which are known to be involved in seizure generation and propagation. Several risk factors that may be identified for post-traumatic epilepsy, such as patient early epilepsy after trauma or severe head injury, depressed skull fracture, penetrating injury, or brain contusion. As we see MRI finding in patients with the post-traumatic epilepsy, this is abnormal left superior temporal gyrus showing the cortical thinning and the signal change, which is the hypotense on the T1 and hypertense flare. Epilepsy infectious etiology, bacterial, viral, fungal, and mycobacterial or parasitic infection may be called the seizure, both in acute phases being early clinical presentation, as well as in chronic stage as a result of gliosis. Among these, cysticercosis frequently present with the seizure and can be identified in imaging study. In active phase, the cysticercosis appear as a thin wall, non-enhancing cyst that may have the eccentric located nodule scolex within them. The death of the parasite causes inflammation changes in adjacent brain with the vasogenic edema and enhancement. In the final stage, the calcification occurs. As we said, this is the MRI finding with patient with a cysticercosis. There is a small rounded lesion with the in the right posterior part of the medial temporal lobe, or the low sign, which is the low signal on the T2, and also we see in flaring. The cerebrovascular disorder is also caused epilepsy, mostly the cerebral hemorrhage, infection, degenerative vascular disease affecting the cortex can cause epilepsy. Vascular disease is common in elderly population. Incidence and prevalence of epilepsy are higher in this age group than the younger people. Market increase. Epilepsy in elderly is expected over the coming decade. AV malformation, cavernous hemangioma, or the developmental mental venous anomaly can also cause epilepsy. They involve the cortex layer. The symptom can be caused on the worst by acute hemorrhage on the progressive igloo. Reference and thank you.